So this patient was treated with imatinib. We're getting a lot of referrals for patients where imatinib is still the king. And as we move them through time with response, perhaps the writing is on the wall because the initial transcript level was 89%. And then at 6-month follow-up, we have an 11% transcript level, which is just shy of an early molecular remission. And if we look at the absolute reduction, it's somewhat even greater shortcoming. At 12 months, really little change, and the patient it does not have a cytogenetic complete remission, maybe a near cytogenetic complete remission. So we're seeing with subsequent milestones, this patient is really considered suboptimal or failing early molecular response, maybe considered to be missing an optimal cytogenetic response at 12 months, and then at 18 months has a cytogenetic complete remission, which is encouraging, but transcripts are still at 1%.
So I agree with Elias that we would have as well probably selected a second-generation drug for this patient. But Mike, as this patient started imatinib, would you have started with 400 milligrams? Would you have continued that dose, or might we have considered other doses for that patient, given their treatment history?
I mean, I think, again, fairly old data now, but we know that 600 milligram imatinib is more effective in accelerated phase by all definitions, clinical, clonal evolution, et cetera. I think we all worry about the patient with genetic instability and additional chromosome abnormalities and what might happen relative to BCR-ABL and ABL kinase domain mutations, other molecular changes. So if I only had imatinib, I would have probably elected to use higher doses. I actually tend to favor higher doses of imatinib even in patients without these changes, based on some data that if used optimally, we can sometimes approach or even match the results with second-generation inhibitors with imatinib, for example, from data from the Title I and Title II trials. So I'm a big fan of that if you're using imatinib to think about, say, 600 milligrams. But I agree with everyone's comments that this is a high-risk patient. They have a very inferior survival and response expectation with standard therapy. They may still have the same they may still struggle with even a second-generation inhibitor because this biologically may be a different disease in some ways than just higher so-called risk SEMA without clonal evolution.
So, Mike, for this case, this patient responded essentially at the end of the day, he responded.
Yeah. But
then in retrospect, at 6 months, would you have changed therapy because of 11%, or you have maintained imatinib?
Yeah. So again, I think a decision we're all faced with in the clinic. What do we do with a patient who maybe we've dismissed we didn't pay attention so much to the clonal evolution, and we're just focusing on response? Is that an inadequate response to be a near EMR? I think there is definitely data looking at how patients can improve over time if they're completely missing EMR at 3 months, how many correct to 6 months. This patient didn't really have any correction, so I think some of the data would support the fact that this may not really turn out well, and a change in therapy could be warranted. I tend to have patience and want to wait till 6 months because of that data on the fact that some patients can correct and look at the individual patient's change. So I think I can't ignore the cytogenetic abnormalities in this case, but if it was not on my radar and patient was on imatinib, I probably would have said, you're too slow.
Michael, would you want information about what the marrow looks like now and whether or not that additional chromosomal abnormalities changing, going away? Has there even more genetic abnormalities at that point? This is maybe somebody who at 6 months, marginal response, I might be looking at a bone marrow early to, again, repeat the formal karyotype to really understand what's going on with that additional change.
Well, we heard earlier, I mean, that reliably, the only really way to get a good karyotype is through bone marrow cytogenetics. So when you have a patient that's got clonal evolution at diagnosis, I think that's the patient who needs follow-up bone marrow studies to confirm clonal changes, present, absent, evolving, confirm cytogenetic complete remission. So I agree completely that a follow-up bone marrow would have been something I would have done, even if they had a beautiful response.